Welcome to Pharmacology Insights, where we break down complex pharmacology into simple, easy-to-understand concepts. Ever wondered how a medication that helps the heart could interfere with blood sugar control? Let's talk about beta blockers. Drugs like propranolol, metoprolol, and atenolol. They're widely used to treat conditions like high blood pressure, angina, heart failure, and even migraine and anxiety. But for people living with diabetes, especially if they are on insulin or sulfonylureas, beta blockers come with a hidden risk. They can mask hypoglycemia, making it harder to recognize when blood sugar is dangerously low. When your blood sugar or glucose levels drop too low, your body springs into action. It triggers a counter-regulatory response to raise your blood sugar up. A major player in this response is the sympathetic nervous system. Activation of the sympathetic nervous system triggers the release of adrenaline, also known as epinephrine. Adrenaline binds to beta-adrenergic receptors throughout the body, triggering a set of responses. Activation of beta-1 receptors in the heart increases heart rate. Activation of beta-2 receptors in skeletal muscle causes tremors. And activation of beta-2 receptors in the liver stimulates glycogenolysis, releasing glucose into the bloodstream. These are just some examples of beta-adrenergic-mediated responses. And these responses are what made up the classic early warning signs of hypoglycemia: tremor, rapid heartbeat, and that anxious, jittery feeling. All signs that it's time to eat and replenish blood sugar. Now here's where beta blockers come in. These drugs block beta-adrenergic receptors either selectively, targeting beta-1, or non-selectively, targeting both beta-1 and beta-2. The first problem is impaired glucose release. In the liver, beta-2 receptors play a critical role in the body's response to hypoglycemia. When activated by adrenaline, they stimulate glycogenolysis, the breakdown of stored glycogen into glucose, helping to raise blood sugar levels quickly. But when a non-selective beta blocker is on board, these beta-2 receptors are blocked. That means the liver can't release glucose as effectively during hypoglycemia. As a result, low blood sugar episodes may last longer and become more severe. And then there's a second, and arguably more dangerous problem. During hypoglycemia, adrenaline activates beta-adrenergic receptors to produce early warning signs. Beta-1 receptors in the heart increase heart rate, beta-2 receptors in skeletal muscle cause tremors, and both beta-1 and beta-2 receptors, along with central adrenergic stimulation, contribute to the jittery, anxious feeling. These symptoms are crucial cues that alert the person to eat and restore blood glucose. However, beta blockers blunt these responses by blocking beta-adrenergic receptors. As a result, there's no racing heart, no tremor, and no nervous energy. The red flags that normally warn of low blood sugar become dangerously muted. Imagine a person with diabetes taking insulin, and also on propranolol, a non-selective beta blocker. Their blood sugar starts to drop. But because glucose release is impaired and the warning signs are masked, they don't feel it until it's too late, when confusion or even loss of consciousness kicks in. That's what makes this drug interaction so dangerous. Let's recap why beta blockers can mask hypoglycemia. They block beta-2-mediated glycogenolysis, causing less glucose release during hypoglycemia. Beta blockers also blunt adrenergic warning signs, leading to less awareness of low blood sugar. Cardioselective beta blockers, such as metoprolol and atenolol, are safer but still carry some risk. So, if a patient with diabetes is on beta blockers, careful glucose monitoring is essential. And that's it for today's pharmacology video. If you enjoyed this video, please give it a thumbs up and subscribe to the channel for more pharmacology content.